All right, guys, picking up where we left off in the previous lecture, we are talking about pre-op prep, and we discussed things like how to orient them to the room, let them know what kind of tubes to be expecting. We also talked about preparing the skin prep, and then why they had to be NPO after midnight. So picking up from there, another thing that we need to talk about is bowel cleansing regimens. Sometimes patients need a bowel cleansing regimen prior to surgery. Now, while most people believe the entire purpose behind this is to prevent a BM during surgery, that really is not the main purpose. Yes, it will definitely help that, but we don't put patients through this unless we have a good reason for them to need their bowel cleansed. For instance, we're getting ready to do a bowel resection where we know we're going to open the bowel, we're going to cut out a segment of the bowel and then re-anastomose that bowel. During the time that the bowel's open, we don't want there to be a bunch of stool sitting in there leaking into the peritoneum, which could cause peritonitis. So, there are definitive reasons for cleansing the bowel. Most of the types of bowel cleansing that we use can be very exhausting for the patient. Especially, I'm going to talk about Go Lightly in a second, but Go Lightly is very exhausting. It's not fun to, be constantly running to the bathroom. It's not fun to experience all the abdominal cramping that comes along with that. And if you start this later in the evening, some of these things like Go Lightly and mag citrate especially, they can go on for hours. So, it could be, if you start this thing at 8 o'clock at night, at midnight 1, 2, they still may be going. That's not going to be conducive to getting them good rest or sleep prior to the surgery. Another thing that we may need to do is an enema. Usually enemas are reserved for times when we really only need to clear out the colon. For instance, if we are, doing some type of endoscopy procedure, or if we are doing a hemorrhoidectomy where there are internal hemorrhoids inside the rectum, you need to go up inside there, well, you need that to be clean. Go Lightly and mag citrate are oral bowel irritants, and they will literally clean from the top to the bottom. Things like a soap suds enema or Castile soap enema, or a Fleet's enema, which is a more chemical osmolar type of enema, those are going to just clean out the colon. So it kind of just depends on what the doctor needs, what type you'll be administering. They do help to decrease distension and reduce the risk of a post-op ileus, but your best friend in reducing the risk of a post-op ileus is getting that patient up and ambulating them as soon as possible and making sure that we're not just doing the absolute minimum. If the doctor says ambulate TID, that's great, but if you can get them up 4 times a day, that's probably going to be better. Sometimes we'll also use antibiotics to help decrease the organisms in the bowel. I'm a urology nurse, and so one of the surgeries we do are urinary diversions. If we're going to use a section of bowel to create an ileal conduit or multiple sections of bowel to create a continent diversion, we don't want that bowel to have a ton of normal flora in it when we initially hook it up to the ureters. So we will use something like erythromycin base or neomycin base, give a fairly good dose of that in the 12 hours prior to surgery to help try to kill off some of that normal flora for just that purpose. All right. The next thing we need to talk about is informed consent. Now, you have talked about this before. The first time you ran into this would have been back in PVC. Informed consent is not just a signature on a piece of paper. Informed consent has to actually be obtained by the physician. When the physician explains the risks and benefits of having the procedure and also the risks of not having the procedure, and then any other options that they may have, that's their job to make sure that explanation is done and done with a particular degree of effectiveness. Nurses, however, may clarify something. If a patient just has a question and says, I didn't understand what this word meant, you certainly can define that word and make sure they understand what that word meant. But if the patient's asking you 10 questions and it's pretty clear you're getting the definitive feeling that this patient really doesn't understand what's about to happen, that is a situation where you're going to want to let the physician know, because that's by definition then, not informed consent. Consent is required for anything invasive and obviously also now these days for blood administration. Now I will say on most operative consents, if you look through all of the fine print, there will be a section in there about blood administration. So some of your patients who do not desire that option, maybe they're a Jehovah's Witness or they just have some other reason why they're not going to give consent for administration of blood or blood products, they will seek that part of the contract and that consent out, and they will strike that out. Patients must be competent to sign that consent. Now, your job is to make sure that they are the person that they say they are, that somebody else isn't signing for the patient, and that they're not on any narcotics or other mind-altering drugs when they sign it. And I'm not saying withhold pain medicine. If somebody's got terrible pain and you need to give them pain medicine, that's fine. Or if the RN needs to give them some IV push pain medicine, that's fine. But you need to get someone else, a significant other, next of kin, to also sign that consent or sign it in place of them, because it doesn't take a rocket scientist to go back and see what time the consent was signed and what time the meds were given. And if the patient argues that they did not provide informed consent, you're going to lose that argument if they are the only ones who signed that consent. They also need to be of legal age. And as much as we like to, kind of help our teenagers to feel like they have some control, a 16-year-old cannot sign their own consent. They can sign it, but I also need the parent to sign it as well. That consent will be saved to the chart, and that consent is actually just a record of the consent. The consent is actually obtained when the physician explains the information. We're just getting a signed piece of paper that records the consent that the patient gave the physician. The other tricky part about this is that it can't be witnessed by anyone on the OR team. So if you're the floor nurse and you have watched the patient sign the document, then you're the one who has to sign as the witness. If a patient comes down to the OR with a consent that is signed but not witnessed, we'll have to send them back to the floor because it's considered a conflict of interest, and it could also be considered coercive if we have the patient sign the consent and we co-sign it. All right, well, I was just talking about rest and sleep and how something like a bowel cleansing regimen can interrupt that. But it's really imperative to have good sleep and get adequate rest. That increases their physical and mental strength. And because of that, you need to be organized. You don't want to awaken a patient for routine things in the middle of the night if they happen to be there the night before surgery, just because you forgot to do something earlier. It's really imperative that they get as good a night's sleep possible. Now, I know that's difficult. How many people are nervous the night before they have surgery? But we need to try as best we can. And a lot of patients will say, well, it doesn't matter if I don't sleep tonight. I think I'm going to be asleep all day tomorrow. That's not sleep. There is a difference between unconsciousness and sleep. Sleep is restorative. Unconsciousness is not. So even though they're going to, quote unquote, be unconscious during their surgery, they're not sleeping. Sleeping is something that actually helps you. Unconsciousness is just helping you get through the procedure. Now, medications are sometimes ordered to help patients sleep, but they're tricky. If a patient is not settling down and ready to go to sleep by about 9, 10 o'clock at night, and they, if they're having trouble, it's okay at 9, 10 o'clock at night to give that sleeping pill. But if you wait till 1 a.m. and then give that patient that sleeping pill, it's going to take effect closer to 2, and then you're getting them up at 5 so they can take their shower and be ready for surgery. So if medication is going to be used, it really needs to be used earlier in the evening to get them settled down and have an adequate time for that sleep aid to be effective. Okay, so say that the OR has called and they're ready to come get the patient. This is the immediate post or pre-op time where you need to check the chart, make sure everything's up to date, make sure everything is there. Now, back in the good old days, we actually had to go find films and MRIs and things like that to send to the lab or to send to the OR. These days, most of that is electronic, but I will tell you, Some of the older doctors especially still like to look at those films. So occasionally you may have some x-rays that you have to send along with the patient to the operating room. Somewhere on that chart there should be some baseline vital signs charted. The patient should be in a clean gown, and usually just a gown, because a lot of times people don't realize that they may be coming into the operating room for a gallbladder surgery, but if you're having a gallbladder, we're going to catheterize you and empty your bladder. So obviously we don't want to wrestle underwear off of people to try to get that procedure done. For hair, for ladies especially with long hair, guys too with long hair, no tiebacks or pins to hold the hair back, nothing that can cause pressure on the back of the head. Sometimes we'll just take one of those blue OR caps and we'll just stuff all their hair up in there, and that calls it good. Makeup, we prefer none, but at the very least no lipstick, and we prefer no nail polish, but if they have nail polish, it just can't be the black variety. We need that pulse oximeter to be able to see through that nail bed and adequately measure oxygen. Valuables should be removed and secured, not just because they can get lost, but if you have a ring or something on that can cause constriction, especially if they swell during the surgery, that can be very problematic. And a lot of patients have prosthetic devices. Guys, these days, prostheses are so amazing that many times you may not realize that a patient has them. Some of them are a little more obvious, but I always tell the story of I had a patient who had a prosthetic eye, but it wasn't like the glass eye. It was an implant that snapped in, and the part that you could see was hand painted to identically match their other eye. And this thing had a 3D quality. When he told me it was not real, I stood there for just a minute and I was just amazed. I was just completely shocked that this guy I'd been talking to for quite a while only had one, working eye. And of course, when he popped it out, I saw what it looked like. It was an amazing thing. And that was like 10 years ago. So don't assume, always ask. And usually the way I say it to people is, do you have anything in you or on you that you didn't come into this world with? And that's, a good way for them to say, oh yeah, well, I have this or that. Make sure we get them secured. Make sure that someone takes possession of them, because prosthetics are also very expensive and not easy to replace. Now, the ID bracelet, there's a reason this is in capital letters. It is imperative. Check it twice. Once the patient is asleep, they can't make any corrections on that ID bracelet. So when I hold their bracelet and I look at it, I don't say, are you John Smith? I say, can you please tell me your name? And when they say the name, then I'm double checking it as I'm looking at the band. And then of course you're asking date of birth and any other relevant information that you need at that moment. And then obviously if they're on the way to get the patient from the operating room, have them go ahead and void. I don't care if you went and void 30 minutes earlier. If you're nervous, you can go again. And there are no bathrooms in the holding areas, so there's really no place for the patient to go once they get down there. Now you're also going to want to check and see if any pre-meds have been ordered for the patient. Sometimes different medications are ordered by the doctor to kind of help get the patient settled down for surgery. A real common one is a sedative. Sedatives help promote rest and reduce anxiety, and they might actually order that a full hour or two before they go down to the operating room. Narcotics, I know that seems weird. Hey, they're not in pain yet. They haven't had the surgery. But, some people are in pain and that's why they need surgery, but that's not why we give it. Narcotics can actually enhance anesthesia. They can make the anesthesia work a little better. And the way a narcotic works, yes, there's a time limit to it, but when that narcotic is not being taken up immediately because the patient's not in a pain, it leaves a little bit of it kind of still floating around in their system and kind of gives you a little bit of narcotic on board for when they start waking up. Antiemetics, there are a lot of times, by the way, they are antihistamines in the world of pre and post-op, but antiemetics decrease nausea and vomiting. decrease the risk of aspiration, and they come in pretty handy. Anticholinergics help to dry secretions, and that can also be handy because sometimes what actually makes a patient throw up is, some of the secretions that were pooling in the back of their throat, or, something, they kind of get caught in there and they go to try to cough it up, and coughing leads to really hard coughing, which then leads to retching, and before you know it, you got people throwing up. And then you have your amnestics. I mentioned this earlier, but there is an amnestic that we use, Versed, that eliminates memory for a short period of time. What people don't realize is anesthesia is not just about going to sleep, it's about not remembering. And so those amnestics come in very handy. So before your pre-op meds, before you give any type of pre-op meds, first of all, make sure that consent is signed, because after you give any of those meds, you're not going to be able to have them sign that consent. And then after you give the pre-op meds, make sure safety precautions are in place. This is when the side rails need to be up. This is when they need to be told, okay, you definitely now don't get up to go to the bathroom without assistance. Now, what about kiddos? Well, a lot of times children have a security item. Maybe it's a teddy bear or some kind of stuffed animal that they really like. We will allow them to take that security item to the OR. Stuffed animals are very good to promote interactive play. A lot of times the child will tell you that the bear is hurting when they're actually hurting, because they're waiting to see what you're going to do to the bear. And they're going to decide whether or not that's okay with them before they say that they are hurting. When I can tell you as an OR nurse, when we take a kiddo into the operating room and they're asleep and the surgery's underway, obviously the security item, I pull that away from them once they're asleep, but I will take an OR hat. We've got a special way we can fold it. We put the OR hat on the bear. We make a little mask for the bear. And wherever the kiddo had a surgery, maybe it was an appendectomy, we're going to put a Band-Aid down that right lower quadrant over the incision site on the animal. So the animal looks just like they do when they come out of surgery. Also, be very careful with kids when you're transferring from, the stretcher back and forth. They tend to kind of lunge. And sometimes they have had their first pre-med, and basically what that amounts to is a kid having their first frat party, and they're like 3 years old, and they are just completely loopy, and they have no idea how, unsafe and unsteady they are. So just keep your eye on them. They can be a little bit crazy. Now, what if you're the nurse on the floor getting ready for the patient to come back from surgery? Well, first of all, we want to make sure those rooms are not terribly warm, but we don't want them super cold. I've really never had a patient come back from surgery and tell me that they're hot. They're always telling me they're cold. That's one of the reasons so many post-op floors now have blanket warmers on their floors. I want to make it easy to access their bed, so I'm probably going to kind of cant their bed somewhat to the side so it makes it easier for me to get the gurney in there when they arrive. I'm also going to fold down the covers. There's a way to make a post-op bed. If you can ask your instructor about that or ask them to show you, but there's a couple of different ways to do it. But the bottom line is just to make it very easy to get the patient into the bed and not have to fight covers and things like that. You also need to think about what kind of equipment you need. If this patient just had a bowel resection, I'm pretty positive they are going to come to me with an NG tube. So I need to make sure I have an NG collection device and a suction device that goes into the wall already in place, so when they come to me, all I have to do is hook that NG tube up to it. I'm also pretty positive anybody coming from the operating room is going to be on O2. So if I have O2 meters on the floor, I'm going to put that on myself. If not, I might have to call respiratory to bring me one down and get it set up, because I need to have those things in place when the patient comes back. I can't be looking for them once they are already there. Now, intraoperatively, when we're in the operating room, there are a lot of things in there that can be hazardous for our patients. The patient is unconscious, or they're at least in an altered level of consciousness, and they can't protect themselves. If your leg were to start to fall off of the table, you would have a protective instinct, and your muscles and tendons would tighten up and pull that leg up before it fell. okay? That's not going to happen when somebody's unconscious. I have to protect them. So I have to make sure that all of the things that they would normally be able to do for themselves, I am doing for them in that operating room. Now, what are some things in the OR that could cause injury? Well, I'd love to get some feedback and see what you're thinking, but hopefully some things that you're thinking are, first of all, we have some very sharp instruments in that operating room. And yes, they have a purpose, but sharp instruments can sometimes be dropped, and that's, another possible area for injury. We also have something called an electrocautery device. The nickname for it is Bovie, and the Bovie has the ability to cut or coagulate using an electrical impulse. That electrical impulse has to be grounded on the patient somewhere. So if that's hard to kind of wrap your head around, ask your instructor. We'll kind of try to explain that. That's something that's probably a little easier explained in person. But, there are many different things. Light cords that we use for fiber optic instruments can get very hot. And if you just lay that light cord down on a drape, you might be forgetting that there is a person under that drape, and it can cause a burn. And I have seen that happen on more than one occasion in the operating room. So these are all things that we have to keep an eye on. As a circulator, that's my job, to kind of keep an eye on that stuff and call people out if they're not doing what they're supposed to do, or if they're not following sterile technique, or if something got contaminated. I'm kind of the watchdog in the room. Obviously, I'm not the only one who's doing that, but I'm the only one that's standing back away from the table, and I have a full view of everything. Now let's talk anesthesia. As I mentioned before, anesthesia is not just, putting people to sleep, because sometimes we don't even put them to sleep. We do a regional anesthesia. But anesthesia usually involves some combination of reduced sensation of pain, amnesia, and the ability to either relax or paralyze certain areas for the duration of the surgery. So the first type of anesthesia that I want to talk about is a general anesthetic. General anesthetic is also abbreviated GETA, and I think it's on the next slide or something, so don't panic, but it's general endotracheal anesthesia. So you can tell just by the name that we are going to intubate this person. So general anesthetic is usually administered in a very systematic way. However, we do tend to reverse this somewhat in kids. So let me tell you about adults first. In an adult, we're going to go ahead and start their IV, and we will start, when we're getting ready to put them under, it's called induction. When we start inducing anesthesia, we are going to put a medication called propofol or Diprivan. This stuff is white. It looks freaky because you're seeing this opaque white stuff going into an IV line. And of course, we're used to things being clear. But we call it the milk of amnesia. But this propofol goes in, and literally, from the time you see it disappear into that IV cannula, count to 3, because your patient's already probably going to be out. That's how quickly it moves. Now, the problem with that rapid induction is their airway is at risk at that point in time. So what you're going to see happening is the nurse anesthetist or the anesthesiologist is going to have a mask kind of just sitting on the patient's face, and they're not really doing anything with it initially, and they're just saying, oh, we're just giving you some extra oxygen. The patient says, okay. We have the patient count. Well, they start back from 100, they get to about 98, and they're gone. Well, now we take that mask and we engage it. We push it down onto their face, we get a good seal, and we start using the ambu bag to provide for respirations. When we're working on that, we're waiting on that induction to fully take place. Just because they started going out doesn't mean they're fully under to where we could intubate them. So for that minute or so that we're waiting for that to happen, the anesthesiologist or nurse anesthetist are actually providing them breaths with the ambu bag. Now, there'll come a point at which they'll test with a little electrical device that measures the number of pulses that the muscle fires off on the side of their face. When that becomes sluggish enough, we know that they're under. Now at this point, that's when they're going to intubate them. So they're going to stop giving them breaths, and then they're going to go ahead and put in the laryngoscope, put the ET tube down, inflate the ET tube, immediately hook the ambu bag to the ET tube, and then they'll be setting them up eventually on the ventilator for the rest of the surgery. But for that period of time, that airway is at risk because we do not already have an airway in place. Now, once we get that tube in place, we're going to probably kind of shift away from the IV anesthesia, and we're going to go to the inhaled anesthesia. The nice thing about the inhaled anesthesia is when it's time to wake them back up, it excretes and reverses very rapidly. Pretty much as soon as you turn off the gas, the isoflurane, desflurane, whatever they're using, halothane, you start turning off that gas. I mean, they start coming up out of it really quickly, which is handy. You want them to be able to do that. The problem with those gases is they are very irritating to the lungs. We talked earlier in a previous lecture about the amount of secretions that the lungs normally make. Now that mucociliary escalator is paralyzed, but then on top of that, we're putting gas in the lungs that's irritating, so they're going to make even more secretions. This can also cause some nausea and vomiting. That's one of the side effects of the gas anesthesia. But it's this combination of IV and gas. And by the way, one of the IV meds that we give usually has some amnestic qualities also. So we're getting muscle paralysis, and they have to be somewhat paralyzed, guys, or we can't get that ET tube in them. We're getting reduced sensation, and we're getting amnesia. And that is the cocktail that you put together that provides us with general anesthetic. Now, there are some complications. I've just discussed the irritation of the respiratory tract. But when I was saying before that the airway was at risk, it didn't sound like it was too bad. But one of your biggest worries is from the time you put them under with propofol until you can get them far enough under that you can intubate them, you worry about them having a laryngeal spasm. A laryngeal spasm means that the larynx spasms and will basically close the airway and make it impossible for you to even pass an ET tube. So laryngeal spasms are very dangerous, and if they are bad enough, it could necessitate a trach, at least temporarily, just to open the airway to get some air down in there. Very rare, but it's something that you need to be aware of. Other complications of general, cardiac disturbances, we use a pretty complicated cocktail of drugs that are going to help relax muscles, paralyze, reduce sensation. We also want to reduce blood pressure a little bit and have that amnestic quality. So by the time we mix all of that together, unfortunately, some of those drugs, when they're all together, will cause some cardiac disturbances, maybe some arrhythmias, maybe some just slight problems. So one of the things that you will see if you ever get a chance to go in the operating room is whenever a nurse anesthetist or anesthesiologist is doing a case, they will have a stethoscope. It doesn't look like a normal stethoscope. It looks like this funky plastic tube. But they will have a stethoscope, and they actually put a little sticky thing on there, so instead of them having to hold the stethoscope in place, it sticks to the patient's chest, and that tube will come up, and it's attached to an earpiece. It looks like an earbud. They are listening the entire time. So it's like having a stethoscope in one ear, and then having their other ear open to hear, what's going on in the room. But that person managing the anesthesia for that patient is constantly listening to that heart throughout the entire surgery in order to listen for any cardiac abnormalities. Of course, the other main thing that we're worried about is aspiration. The quintessential thing we want to avoid is aspiration pneumonia. I mentioned in a previous lecture about how we worry that gastric contents that have such a high acidity, or reverse that and say very low pH, if it gets into the lung, it's absolutely going to fry that lung tissue. And aspiration pneumonia has a very high mortality rate. So we do everything possible to prevent that from happening. Keeping the patient NPO, trying to limit their nausea and vomiting, things like that are going to help us prevent that. Also, we do not pull the ET tube until the patient is pretty awake. In fact, sometimes they're kind of almost waiting until the patient's trying to reach up and grab the tube themselves, because they want to make sure they're awake enough that they can swallow, so that they don't aspirate into their lungs. They can swallow any secretions down into their stomach. Okay, the other complication, and it's in bold, and it's got a whole nother slide all to itself coming up in a moment, is malignant hyperthermia. Malignant hyperthermia is a hypermetabolic state, and the best thing that I can tell you on this is do know about it, because it's terrible when it happens, but be slightly comforted in the fact that the very first word on this slide is rare. Okay, it doesn't happen frequently, but when it happens, it's usually a bad deal. It's very, obviously life-threatening. It's a hereditary reaction. Now, what I'd love to tell you is it's a hereditary reaction to XYZ anesthesia. The problem is it is a hereditary reaction to some combination of anesthetics. Well, we don't know what that combination is until we unsuccessfully administer it, and then this happens. So this is why one of the questions an anesthesiologist will always ask a patient in their pre-anesthesia interview is, have you ever had, or has anyone in your family ever had a very bad reaction to anesthesia? And if so, what was that reaction? Because they're trying to determine as early as possible, if this might be an issue. So what happens in the patient? Well, you have to go back to what I said in that previous slide where I said hypermetabolic state. If you think about that, then this next part of this middle part of the slide makes a little more sense. Hypermetabolism means your metabolism is going in overdrive. If your metabolism is going in overdrive, one of the things that metabolism creates is heat. That's why you get hot when you exercise, right? But what this is going to do is this is heat that's not going to be able to dissipate fast enough, so it's going to cause hyperthermia. And I'm not talking a little bit of hyperthermia. I'm talking about temperatures that when you notice it, it's probably 103, 104. They can go 105, 106, and they've been recorded as high as 107. That's horrible, and I think you all know that. Tachycardia, so again, hypermetabolism. But all that tachycardia means if your heart is nipping along at a really fast pace like that, trying to make my hands make the sound, how much time do you have for your heart to fill? Like none. So your cardiac output is zilch, because while the heart's so busy trying to pump so fast, we're not giving the ventricles any time to fill with an actual volume of blood. So the blood pressure is actually going to drop. Then add to that, the patient will start experiencing muscle rigidity. And I want you to remember that the middle layer of your vessels are also muscle. That's what vasodilates and vasoconstricts your muscle. But they become very rigid, okay? This hypermetabolism seizes up the muscle, and in the process of seizing up that muscle, it messes up how the calcium is functioning in that muscle. Remember, you need calcium on that muscle to cause a normal muscle contraction. Remember the actin, the myosin, actinomycin. I know it hurts, but remember that from A&P. So it causes it to break down, leading to a massive release of myoglobin. And remember, even though this is a calcium problem, if I start breaking down cells, what's inside the cell? Potassium. So I'm releasing a bunch of myoglobin, and I'm releasing a bunch of potassium. Well, obviously, hyperkalemia is dangerous all by itself, but add to that the fact that myoglobin has an affinity for the kidneys and will basically clog the glomeruli and make them go into instantaneous renal failure. So your only hope in a situation where you have hyperkalemia is that the kidneys can excrete the excess potassium and you can still be okay. But since that myoglobin is now going to clog your kidneys, you're going to have all that excess potassium not going anywhere, and that will lead to a fatal arrhythmia, and that is usually the reason if they die. That is the reasoning behind it. So what is the treatment? Well, I'm going to tell you that the best treatment for malignant hyperthermia is to prevent it by doing, as thorough of a pre-anesthesia assessment as you can, and make sure that, if there's any risk of this in their family, that we're prepared for it. Barring that, what we try is cooling measures. Every anesthesia department has a refrigerator where they keep iced IV solution. I'm talking IV solution that is so cold, it's probably down around 40 or 38 degrees. And obviously we don't give that fast, but I want you to think about, obviously 38 to 40 degrees is much cooler than we are. So we administer that solution directly into their veins and literally start cooling them from the inside. Then we pack ice packs under their arms, in the groin, in any place, on the abdomen to kind of help cool them down. And then there is also a drug called dantrolene. Dantrolene is a medication that prevents that faulty calcium function. And so if we know in advance that this patient may have this problem, they will try to give them a small dose of dantrolene in advance, so if it starts happening, it gives us more time to get ahead of it. It won't prevent the entire thing, though. I know a lot of you guys are thinking, well, why don't they just give everybody dantrolene? Well, one, it has side effects, and two, it doesn't prevent the entire process. It just gives us more time to react. Okay, a couple of pictures to show you here. The picture in the top left, those are honest-to-goodness ET tubes. So those are endotracheal tubes. Those go down into the trachea, and that little tiny tube off to the side is what we use to inflate that cuff. So unfortunately, in both of these pictures, both cuffs are inflated, so you really can't see when they're deflated. But obviously, when we put that tube in, it's not inflated. When we get that end of the tube past the epiglottis and down into the lung, we inflate that cuff, so if any secretions were to get into the lung, they would sit on top of that cuff. It's one of the reasons why before they extubate somebody, they will often suction down in there and try to get out any secretions. Now, the wonderful device that you see down on the lower right-hand side is called a laryngeal mask airway, or LMA. You might understand that many of us nickname this thing a diaphragm on a stick. But the purpose of this is not to go into the lung. The purpose of this is to basically use the back side of that LMA to block the gastric side and use the front side to be open to the trachea. So instead of it going down into the actual lung, it basically just only provides one option for things to go forward and back. It's not considered as safe as being intubated, but for short surgeries, this is often used so we can decrease the risk of problems. Singers, people who have other throat issues, they do a lot better not being intubated. Okay, I know that we are not quite really to the halfway point, but I'm going to stop the recording here. This is about 40 minutes on this lecture. I will go ahead and pick up with another recording to finish the rest of it. But again, please jot down your questions as you go so that when you meet back up with your instructor, you can ask those questions.